I think we have everyone that we're going to have. My name's Ken Kaiser, and I'm going to be your flight attendant today. The focus of this session is on strategies to encourage research in nurse credentialing. Before we jump into it, the three questions that we were asked to address, just a few ground rules. One is that when you speak, if you would please use the microphone. There will be two microphones. One of the reasons for asking you to move over here was to facilitate the passing of the microphone. The pragmatic reason for that is that if you don't use the microphone, the folks who are participating in the webcast won't be able to hear what is being said. So if you would please try to remember to do that, and I will gently remind you if you should forget, unless of course I forget. Likewise, if you would state your name, that would be helpful. And we will be recording comments instead of using the flip charts, which from looking at the back of the room look like it would probably be too far away to read. Claire's going to be taking notes and projecting them on the screen, and hopefully we will all be able to read that. Did I forget anything in the housekeeping area? Yes, if you would also be so kind as to stand if you're going to make a comment, unless it's just a very quick back and forth sort of thing. With that, let us proceed. We're actually 15 minutes ahead of schedule, which must be a first for an IOM meeting. We have three questions that we were to address. Hopefully everybody has these in front of them. The first question, I'll go through these and then we'll come back to them, is a threshold question. Is there enough evidence to pursue research in nurse credentialing? That is followed by the question of if so, or presumably if so, are there or what are the short-term strategies, short-term being defined within 5 years, to encourage continuous activity in nurse credentialing research, and then that is followed by what are the longer-term strategies, i.e. things more than 5 years out as far as 10 years, and anyone who can see more than 10 years in the healthcare crystal ball these days is quite clairvoyant. But what might be the long-term strategies for encouraging continuous activity in nurse credentialing research? So that's the landscape that we hope to traverse. The idea is at the end of the session, we will have 5 concrete ideas, ideas that could actually be described. This is how you would implement such an idea. For each of the both short and long-term strategies. And at some point along the way, we will do some sort of group exercise to see if we can rank order those 5 things, recognizing that it may or may not be possible to actually rank them. So the first question, is there enough evidence to pursue research in nurse credentialing? A threshold question. Does anyone feel no? Okay, so for purposes of the record, the group by assent, body language, some verbalizations, other body gesticulations indicates that the answer is yes. Let me just ask, push that a little bit further. Is the evidence weak, medium, or strong? So just to try to get a little further refinement on that, how many, who would say that the evidence is weak but adequate? Mm. All right, well, let me actually ask you to explain why you think they are different, and then we'll come back to that. And again, could you stand and...
Hi, Robin Newhouse. I would say that it's very different because the individual credentialing is basically descriptive correlational studies. They're studies that have multiple issues and limitations. They are biased in a number of ways, most often being they are convenience samples. The methods that are used are often in question. The outcomes that are used vary. So individual credentialing, I would say, is weak and poor. So weak in terms of a recommendation and poor in terms of quality. Organizational credentialing, however, has a more robust base. The quality of the evidence is strong. The quantity of the evidence is building, and the consistency of the evidence varies. So there are more questions to be asked.
All right. Before we further pursue that, let me ask the question, should we go back to the first question and ask it with that distinction? Or in the aggregate, does the group feel that it matters? Robin?
So I would propose that it does matter, and it does matter because credentialing is one of the major initiatives or interventions that may lead to improved quality, improved processes of care for us to meet some of the quality gaps. So to me, the fact that it's weak is because that's the state of the evidence and no one is funding this. So it's small studies that are funded by small amounts of money. So it's not that the evidence can't evolve, it's that it hasn't been a funding priority, and that's the reason it hasn't been conducted.
All right, and maybe I wasn't, I'm not sure from your response whether I was clear in what I was asking, but on our original question, is there enough evidence to pursue research in nurse credentialing? Should we repeat that, but asking it two questions, whether there's enough evidence to pursue research in individual nurse credentialing, and secondly, is there enough evidence to pursue research in organizational nurse credentialing, or would the answer be the same and that we don't need to go back? Okay, so the question was asked, the group again by seemingly assent opines that there's enough evidence to pursue research, whether individual or organizational, but now taking it to the next step, the evidence for individual or research in individual credentialing is felt to be weak, and the evidence for organizational credentialing, if I'm trying to summarize what was said, is felt to be stronger, and there was a further comment over here. Yes, sir.
Rick Meadows, and to add to what Robin said, I think we also need to pay attention to the difference between voluntary and mandatory credentialing. There's a significant difference there. From an individual basis, if it's voluntary, then I make my decision based on one set of criteria. If it's mandatory, I make my decision based on another set of criteria.
Okay. Yes, ma'am.
Melissa Beal, and I want to also add on to what Robin said. So I do agree that the individual research, if you're looking specifically about individual credentialing and patient outcomes, is weak. I absolutely agree with that 100%. But I think we have other research around nurse credentialing on the individual nurse that is better than not good. We have good studies that look at the value of nursing certification. While it's not looking at patient outcomes, it is nursing certification research that is better than not good. So I don't want to just talk about individual credentialing research that looks at patient outcomes, because we do have other studies that we've done that I think have moved the profession forward. That is good research, and we shouldn't discount that.
Okay. We got ahead of ourselves just a little bit. The question was whether it was weak. We made that differentiation. Do we have any votes for either individual or organizational credentialing, the evidence being moderate or medium or whatever, somewhat in between, and then the last of whether it's strong?
But I guess I'm making the point that I don't think it's weak and poor, is what I'm saying. I'm saying that it is weak and poor if you're looking at nursing certification and patient outcomes. If you're looking at studies that look at nursing certification at the individual level, for instance, on the value of certification, it isn't weak and poor. So I was just trying to clarify that I don't want it to say it's weak and poor across. It's weak and poor specific to patient outcomes. It's not weak and poor specific to credentialing.
Okay. And Robin was going to make a comment on that, I believe.
No, actually, I just want to make sure that we're talking about the right type of credentialing. So I was absolutely talking about voluntary credentialing, not mandatory credentialing. There is a robust body of evidence related to mandatory credentialing of advanced practice registered nurse. In fact, I think the answer is already made, that there's high quality, good effectiveness for advanced practice registered nurses compared to other groups of providers, either teams or individuals. So there's no question about that whatsoever. So that comment was around individual credentialing and the relationship to outcomes.
Okay. Yes.
Building on what Melissa said, Shannon Carter, Certification Board for Operating Room Nurses. We do have very good data about the value of certification. And in fact, in one of the white papers, I recall reading that we needed to better understand why nurses seek certification. And I would make the case that question has been answered with pretty good research. So we know that both within the OR, and that was replicated by ABNS across specialties, that nurses seek voluntary, to your point, certification for intrinsic reasons, because it builds their profession, it builds their skills, kind of the journey, the process, and less on extrinsic reasons around pay or promotion. Now, that may be changing, but I don't want to have that research left out of the discussion about what is the body of evidence around certification, because that's important, good work that was done both within the OR and then replicated across multiple nursing specialties.
Have we sufficiently beaten this, or are there other points? All right, well, let's move on then to the next question that we were asked to address, and that what are the short-term strategies to encourage continuous activity in nurse credentialing research, short-term again being defined as within a 5-year time horizon. So the floor is open to suggestions for what should be those strategies. Yes, ma'am.
Is that on? Dr. New has said once you get this, it's yours. So I'll be done after this. But you know, I heard a lot of talk yesterday around the lack of data and the lack of a centralized repository for important data around nursing credentialing. And it seems to me that there's an opportunity for the right body, the American Board of Nursing Specialties, the Institute for Credentialing Excellence, some of those people that work in certification, to take a lead role and convene their stakeholders and encourage people to be more transparent with data to build that repository. So, you know, to me, if we can get a group to say, look, share with us the people you have that are certified, the number of people you have, what are the characteristics, the demographics, their behavior, we take a great leap into being able to address what is a major gap in the knowledge base. And I also think that there are vendor partners, industry partners, technology partners that we could work better with to design databases that will help move us forward. So I see kind of a data repository project as being a key short-term, pretty actualizable strategy in the next, you know, 1 to 5 years.
Before you sit down, let me push you just a little bit on that, because again, part of what we hope will come out of this are things that could be operationalized. But I know over my career I've set up quite a number of data repositories, from cancer registries and birth defects monitoring programs and other sorts of things. They all cost.
Right.
So as you make that recommendation, what's the corollary of how it would be supported, both initially to establish it and then on an ongoing basis?
Well, and I'll speak for the Certification Board for OR nurses as both, I think, active members of ABNS. and well as ICE. I think it's up to the members to put their money where their mouth is. And we can't keep sitting here as members and saying, well, you need to do this ABNS, you need to do this ICE. We need to be willing to commit funds. And there are groups in this room, mine included, that have the funds to not pay for the entire project, but to commit a significant amount of funds to what is, I believe, our future. So I would be willing to engage in a conversation of what does it look like? What does it cost? And the expectation is that we collectively contribute money, but I will tell you, I think money is only part of it. I think it's willingness to share information is the other part of it. So we can't have a project or a program or a database that has value if we only have half of the people saying, I'll play, I'll contribute. So even if you have groups that will pay most of the dollars, if you have 4 or 5 members who will contribute most of the money, on an ongoing basis, it has to be more collectively shared. So you could have big organizations give the seed money, but that members need to understand dues are going to look different because you're contributing to what is a core asset for the organization, and you need to contribute data. And if you're not willing to do that, then say so up front, because nothing's more frustrating than trying to do coalition or committee work, design a project, move forward, and then have half or the largest or the 2 largest groups say, yeah, we're not going to share our information, because it renders the whole project, or it kind of, to be crude, kind of neuters the whole project up front. That would be my recommendation.
One of the caveats on any database is that if they're going to have longevity or long-term viability, they have to demonstrate their value. They have to be utilized, and that they have to demonstrate some return on investment for the folks who are supporting them. So that conversation gave us, everyone, a chance to think about what their other strategies are. So we have one recommendation. What's a second?
I'm Marla Weston with the American Nurses Association, and when I think about one of the short-term strategies, I do think this has to be linked to the triple aim. I mean, we've already talked about how we have data on what nurses see as the value of credentialing, but that's not going to really move the body of the research. We need to understand how credentialing relates to things like the quality of patient care, the cost of patient care. So one of my suggestions about a short-term strategy would be that the centralized data repository is somehow linked to outcome measurements so that we understand how credentialing does relate to patient care. So it might not be inventing our own database. It might be linking with another database and adding in credentialing data to get a more robust picture of how credentialing actually relates to patient cost, access, and quality of outcomes.
So both of these really have to do with mobility of data and making the data that is available more accessible for those who wish to pursue investigations, somewhat different themes on the same idea. Someone had their hand? Yes, ma'am.
Decker from Texas Tech. Wonderful data, good, but I think we have to agree on what are we going to collect. Otherwise, we're going to have multiple people gathering multiple data. We've got to pull it all together.
I'll say, okay, so is this an opportunity, or is this something that an entity like the National Quality Forum should be tasked to identify what are the data elements that would be most useful, or is this something that should be done internally, or how are we going to agree on those data elements?
Okay, now? There you go. I'm Maureen Cahill, and I lead the APRN campaign for consensus for the National Council of State Boards of Nursing. We've had conversations with our certification programs for APRNs about our APRN nurses database, which is a licensure-based database, and is there the ability to have them push in certification information to that database and then make it useful to those programs or to others in conducting research or, you know, looking at separate populations. The same technically could happen with the RN nurses database, which is a very vigorous database now for licensure and discipline data. It's a little bit different in the RN level because it's voluntary, right? And so maybe the certificant themselves has to give some sort of an approval for the sharing of that data. But the APRN database, of course, it's an element of licensure, so it's required for the boards to have that access. So that's another place that maybe we could all talk about and think about. Would that be a good repository for this kind of information?
Yes.
So it is on, yes. Cindy Miller Murphy with ONCC. I just have concerns about the outcome piece. I know how important it is, but my concern is about specialties. And we're looking at specialty certification, and the whole point of it is becoming very highly specialized and knowledgeable about your area. And what's important for us in oncology may not be important for another specialty. And I think we have to be really careful. We already looked at the NDNQI data, and we looked at things like falls and skin breakdown, which, broad strokes, that's good. But I think when we drilled down to the data, we found that people in ICU don't fall because they don't get out of bed, but they have really bad skin breakdown because they have multi-system failure. And so how do you sort that out? And so I think that's kind of a concern. I don't have an answer. It's just a question to throw out there. How do we do that?
The conversation has skewed very much towards the data, but I want to make sure that we are maintaining a broad view of what the potential strategies are. I would throw out that the universal elixir for research is money from any flavor. It will stimulate research. So are there things in this regard that we should be thinking about as far as stimulants to encourage research? And before we get that, there was, I cut someone off here. Yes.
Well, Judy Martin Holland from UCSF, but I was going to comment similar to Cindy. So if you want to take it in a different direction, I'm happy.
No, make your comment and then we'll go.
My comment would be to agree with her around the outcomes piece, because it's not clear to me what indicators we would be following to make sure that we could identify the outcomes that really represent nurses' work in any of the specialties. So my caution is to jump ahead to look at outcomes without having done the work of identifying the indicators that would really represent us.
Okay. Yes.
Vicki Lundmark, ANCC. Both of the comments I just heard raise thoughts that I've had many times working with the standing committee and here at the workshop. All certifications, I think, would not have the same outcomes. Yesterday, we heard somebody recite all the different gerontological certifications there are. Well, I presume that each one of them have a more specialized role, and what are the outcomes that relate to that? Maybe something the certifying bodies could help us do, some convening fashion, is to identify the low-hanging fruit for research questions, where, like Cindy Murphy's suggestion about the outcomes that matter, pressure ulcers to the ICU, we could identify some of those as more readily accessible to research findings that will help us find our way to a larger body.
So let me see if I got the essence of what you were saying. And again, we're trying to turn this into concrete recommendations. Is that you would ask that the certifying bodies identify what are the critical questions that need to be answered in the different specialty areas, and that would be ostensibly a stimulus then to encourage research, or at least prioritize research in those areas?
Yes, I think so. A lot of the studies you see now, sometimes you don't even know what the certifications are that are in the studies, and they're being linked to outcomes. And I've had similar thoughts with organizational credentialing too. I keep wondering which magnet standards matter most to pressure ulcers or patient satisfaction or this and that.
So again, just to try to make this concrete, how will that, and this is to everybody, how would that knowledge or those questions stimulate research in the short term? I mean, no question, good questions, valid questions, things that need, but how does having those things stimulate or encourage research in and of itself. And again, that's part of the distinction that we need to make as we go forward is what are the things that actually will catalyze the research as opposed to what are the research questions or the issues that need to be studied. So that was a question. All right, and as you're thinking about that, let's come back to where I was starting to push you to think about funding. And again, it's axiomatic in research that if someone puts money up, there will be investigators that will respond. So if funding is the elixir here, how might we think about, or what might be ways to encourage funding to support or catalyze research in this area?
This is Maureen Cahill again from NCSBN. Going to be a very APRN specific answer because that's my area, but I'm very interested in the area of diagnostic accuracy for APRNs and for the rest of the interprofessional team. It's one place we know we don't do really well, and so knowing that, is that a focus, and can we partner for research funding with some of the organizations that are really looking, or the businesses that are really looking at tools that enhance diagnostic accuracy. So I think of IBM and Watson and some of the health initiatives. That is there a way to kind of partner with some of those industries to tackle that piece and really focus on, and we don't know what the outcomes are for diagnostic accuracy by the different APRN roles. We just know that it's the #1 reason for closed claims, both for APRNs and for physicians.
So again, just taking that, what I hear you saying is that perhaps some effort should be made to work with payers, whether they be business coalitions or other payers with the purpose of trying to increase diagnostic accuracy?
Yes.
Okay. Other ideas in the back?
Marla Weston again from the American Nurses Association. I'm thinking specifically about the area of voluntary individual credentialing, which is a place where I think we've got to jumpstart the research. And so when I think about encouraging research in that area, I think both of funding and getting novice researchers started on a journey of that being their career-long research area. And what I'm thinking about is what are the things that are within our control? Because it's really easy to jump to, AHRQ should be funding this, and that's a big jump. But so when I think about what are the things that are within our control, the American Nurses Foundation offers some funding for research in this area. I'm looking at many people around the room who fund research programs within their own organizations or through the American Nurses Foundation that we could target for a year or two around this body of work. I'm also thinking about a meeting that's coming up called CANS. Somebody here is going to have to help me, but it's something like the Council for Advancement of Nursing Science. And it's really nurse researchers that do research in the area of health systems research. We should be having a program there about, and a lot of novice researchers, a lot of doctoral students go there. We should be having a program there about this body of research and the opportunities and the funding to get some of these novice researchers started on a career trajectory along this area. So I'm kind of thinking in that, what is within our control that we could get started? Because this is a decade or two of work. So how do we get started in the next 1 to 5 years? Oh, here's another idea.
All ideas are
sorry,
welcome.
just to get them all out. Because once you have the microphone, it's yours. The magnet multi-research study project, that I really mutilated that, which is bad. But it would be interesting to have this be an area of focus within that multi-research or multi-centered study. So someone's going to help me here, I can tell. Thank you.
So I'm Karen Haller. I'm the Chief Nursing Officer at Johns Hopkins in Baltimore, but I also have served the past 2 years as the chair of the ANCC Research Council, which sponsored the multi-site studies that we've done. And essentially, this is a crowdsourcing method of funding the research. It acknowledges that many of the questions we're interested in are not going to be taken up by RWJ or AHRQ or NINR. And it says if we want to move this forward, we crowdsource it. And so we have crowdsourced grants across the magnet hospitals, getting 30 to 40 hospitals to participate in a multi-year study and paying a fee for that of 20 to 30K depending on the study. So I was thinking, is there an analogy here? How could we crowdsource some of this work, and who do we crowdsource it to? And it might be the sponsors here who pool their fund of money, because you all have small research pots. You don't have large buckets of money. But if you crowdsource the question and you agreed that you would competitively ask for proposals and review them, it's a mechanism of funding, self-funding to start up the initiatives. So I'm fascinated by this idea of crowdfunding. It's sort of the latest thing out there. We've played with it at the ANCC, and I'd be interested in what other people think of that.
Would anyone like for her to explain more what that means, or is everyone comfortable understanding what that means?
Hello, I'm Bonnie Niebuhr with the American Board of Nursing Specialties, and along those same lines, we have successfully used a coalition model of our member organizations to fund research in the past. So I think we do have those sorts of funds available, and we will certainly want to pursue that within our own strategic plan for research. And once the questions are identified, we can deal with that effectively.
There have been multiple suggestions for ways to fund things. I wonder if at this point we could try to prioritize these. Again, part of the drill here is to try to get some things that might be operationable in the short term. If we looked at, and again, if we take it as more or less a given that funding would help catalyze or stimulate activity in this area of research, would anyone venture some sort of prioritization of where that funding should come from? Should it come from the associations? Should it come from trying to get the government and whatever organization, whether ARC or NIH or some other entity, to support it? Should it come from payers as part of their delivery? Should it come from business coalitions? Should it come from industry? Your thoughts on the potential prioritization of where we should be seeking funding to support these efforts?
Cindy Miller Murphy from ONCC. I think the easiest way is for us to do it. I mean, that's the way to get started. I don't know, I'm asking Bonnie, could ABNS have a capital campaign? I mean, became a 501c3 for that reason. So, and it wouldn't just be the members of ABNS, it would be our professional associations we're affiliated with. Capital campaign can go to anyone. Individuals can go to the physicians they work with and say, do you want to contribute to this? That would be short term, I think, the easiest way to get going. But as far as the other strategies go, I mean, we've tried to work with payers for years and they've been a little resistant. But if we could get it in, I think that would be next, I would think.
Other thoughts in this regard?
Maria Shari, President of the American Board of Nursing Specialties. If we're going to achieve impact, we need to have focus. And so I would propose that we look at the model that has been presented, to adopt the model either as it's been presented or modified for whatever makes sense for all of us, and then target an area of focus. And as we target that area of focus, make the decision based in part of where the money might most likely come from or could come from, and align that with meaningful research questions that can help us move forward quickly.
And another way of saying, I think, what you're suggesting is that there should be formal priorities for research.
Absolutely.
Okay. So is it reasonable or practical that this sector of nursing can come together and identify what the top 3 to 5 priorities would be to fund?
Melissa Beal. Well, I think we've done that. From the perspective of ABNS and ANCC, we have research agendas. We've published research agendas. We have published conceptual models. So I think we've moved there. I don't think that I think we can all agree, well, maybe that's what we need to say, is that we all agree that we've done that, and that we can now move the next step beyond conceptual model, beyond the research agenda, and figure out what we're going to do. I feel that yesterday we heard a lot of what is hard. It's going to be hard. There's some things that are going to be really hard. Data, money, tying patient outcomes to individual nurse credentialing. So I think what you're hearing us say is we have an idea of where we need to go next, what the interim steps are. We know we can't, right at this moment, connect an individual nurse credential to a patient outcome. There's too many things in between that have to happen. So we either need to start down the road of addressing each of those things to get us there, or we need to come up with some interim steps of other things we could do. We heard yesterday, and maybe this could go on the list if people agree, that one of the outcomes we could look at is workforce outcomes, not necessarily patient outcomes. Does certification make a difference in workforce? Are certified nurses more likely to keep their, have better job satisfaction or less turnover or more intent to stay? And that might be a question where we do have data access to and we can answer, and it still is looking at an outcome that would address the market of, well, yeah, I want to hire certified nurses because they don't turn over as much. So I think we've made a lot of progress. We just need to decide what the next steps are.
Okay, so let's just take the peel the onion one layer deeper. That's not a very good metaphor, but should that agreement, or at least the formal statement of agreement, I will take it as a given and somewhat by the nods of assent from others, as you were saying, that there is agreement. If that's the case, should some independent entity like the IOM or others be the voice that articulates what that agreement is, or should that come from a particular entity within nursing, the nursing sector, or how would that agreement on the priorities be articulated in a way that would work best?
I would say Sharon Decker, which voice gives us the most power behind it?
And your vote for that would be?
That's my question to the group. I think that's what we need to think about is who, by saying it, would push it faster forward.
And when you say power, what you, I think, are meaning is would garner the most support or agreement, that it actually does reflect agreement among the parties. So let me ask suggestions on who that entity might be.
Bonnie Niebuhr from ABNS. I don't think it has to be one or another. I think it's a partnership of entities that could make the case for why this is so important. Certainly nursing is going to be the one to drive this. in my mind anyway. But I don't think we have to say IOM would be more powerful or nursing would be more powerful. Let's work together to do that and have a stronger message.
Okay, but some entity has to articulate it and be the voice. And maybe that could be a partnership, maybe it could be something else. But that voice has to have credibility and be viewed as being independent and dispassionate about the outcome and not having any particular vested interest in what the outcome is. So there are certain attributes that go with the voice if it's going to have credibility in the long term. Other thoughts in this regard? Okay, again, coming back to the question, what are the levers to catalyze activity in this regard? We can call them strategies or levers, sometimes how I think about it. Funding is one, establishing priorities, getting agreement on what's most important or most pressing. What are other levers that we could use to leverage the outcome being continuous research in the short term in this area? One of the ones that is used in some settings are mandates, whether they come from government, whether they come from payers, whether they come from vested interests. That or one of the ways of encouraging research is when someone says, well, you must be certified, you must do something, and which always then evokes pushback and saying no, because the data is not good enough or whatever. So should some entity take the position in some ways just to catalyze a research of trying to force a mandate, or is that just a dumb strategy because they always get opposed anyway, but it does have the effect often of encouraging activity? And if so, who and what might be the mandate?
Bit. It could be a little longer than 5 years. Sorry, Vicki Lundmark, ANCC. One of the thoughts I have is, let's say that we were able to get a pretty good database together and make it available to researchers. And I am naive about this because I'm not in an academic setting, but would there be value in somehow getting faculties of schools of nursing with doctoral students who have research projects to do tied into this data availability and to training new researchers to understand the data and all the issues that we've been hearing about yesterday?
Perhaps one of the ways that you determine whether there's value in academic activities is whether the market is willing to pay for it and support it when those students or trainees come out the other end. And so I guess I would come back, and what's your sense, and particularly because you're not in academia, what's your sense about what the market would bear or support in this regard?
I was only thinking about the need of PhD students to do good research and their interest in these questions. And so that's a market of a different color that I think could be brought to bear on moving the agenda.
No, and I don't think anyone would disagree that that's an important and useful market, but as in any market, someone has to pay for it. So who is going to find it in their interest and such that they would be willing to pay for it?
Don't students have to pay for data sets sometimes?
If they have money. Okay, good point. Other ideas, and let's just come back to this, because actually we may want to just dismiss this idea entirely that there should be any mandates. And if we don't want to dismiss it, then in what ways or in what settings or what forms might this be something that would actually be a good catalyst for stimulating research in this area? Yes.
Melissa Beal. I think mandates is a great idea. I think we've seen it work with APRN, right? I mean, So I think it's certainly, I don't know that it's a 1 to 5 year plan. It may be in the 5 to 10 year plan, but I don't think we should dismiss it. I think it certainly is an opportunity and something we should consider.
All right, so you don't get off that easy. If it's a good idea, who affects the mandate, and what might the mandate look like?
Okay, I'm going to plead ignorance on that. I can conceptually agree that it's a great idea, but I don't know the specifics of it. Somebody else here would know more than I do.
Okay, because all these strategies in the end have to be operationalized. We have to turn them into concrete action.
Maria Shari, ABNS. I want to go back to that point related to the levers that could encourage continuous research activity in academic institutions. A potential venue might be those organizations that are involved in academic practice partnerships. Those institutions, for example, the service side of those institutions is dealing with the whole triple aim piece and how to basically conquer it. We in academic institutions are going to need to teach our professionals to be able to be impactful in those environments. So what if we targeted academic practice partnerships in collaboration with the American Association of Colleges of Nurses and the American Organization of Nurse Executives, and maybe have some sort of field experiment where we use credentialing to document the unique value of nursing's contribution to those institutions that have to document the triple aim.
Well, that prompts me to share, perhaps unwisely, but one of my biggest disappointments in the institution where I've been for the last 3 years is the seeming lack of curiosity in exploring these sorts of questions. And it's not unique to the institution I am, but I think it's pervasive throughout academia, that these institutions, which are fundamentally about creating knowledge and learning, but also certainly academic health centers are very much in the business of healthcare and delivery. They are not marrying up these things and internally asking these sorts of questions and themselves exploring and conducting the internal research supported by the institution to at least answer those questions at the, perhaps the micro level, but most academic institutions are pretty substantial. And I find curious at a minimum why there isn't more interest in self-generated research that would be to the advantage of the academic health center to answer these questions at the same time that they're, having a throughput of creating PhDs and, others, but they're not marrying up these seemingly two disparate sides of the same house. So any reaction, is that a shared sentiment?
This is Karen Haller, Chief Nursing Officer at Hopkins. So Maria's passed me the microphone here because I'm at one of these academic centers that probably don't marry up the academic side with the service side as well as we could. But I would say what drives those marriages are the funding sources. When there's grant money available, the marriage occurs. And again, without beating a dead horse, this is why crowdfunding worked for the magnet program. Because when we married up the academic and the service side to answer a question in the projects we took on and we funded across 40 hospitals, we created this incentive for that partnership to happen. And oh, by the way, you got credit for meeting a magnet standard if you did it. So there was an added incentive in the pool for those academic service centers to move forward. So it's the same problem. I think I appreciate your point, but I think money helps that academic service partnership to do the research.
And I'm mindful of the margin that most academic health centers operate on, which is typically several times greater than the margin that most community hospitals operate on. I know in concrete detail that, for example, in the University of California academic health centers, and frankly, I don't have much sympathy for that argument that there isn't money to support these types of investigations, because when they're done in-house, using students, using staff, they're very cheap. There's no indirects. There's a whole lot of economies. So I hear your statement, but I'm not sure how far I buy into it.
So in my own defense, I have to say I'm in the state of Maryland, which is a single payer state and the only one in the nation. So those margins don't exist in our
They're
state.
not as great. Yes, I
Yes,
would agree.
I
Yeah.
had to say that in my own defense. Uh, but you're also competing for the time and attention of researchers who will go where the money goes. So yes, even if you can fund it, your researchers' attention tends to go where they can get the grant money. That's where their academic careers are built. It's just part of the fabric.
Understand, but there's more to it. Maybe you're from the University of California, San Francisco?
So, Judy Martin Holland from UCSF, and I understand the question, and I'm not sure what the answer is. I think perhaps one of the strategies might be to bring some of the nursing leadership together from both the academic side as well as the service side to help develop a research priority for the institution, and then to have the really difficult conversation about funding that activity. And I think all of our UC hospitals have a nurse researcher and a group of staff that they're either overseeing or working with. And so that's the group I would look to help us with these questions. And the payer source would be the facility.
I mean, too often the academic
Absolutely.
side of the nursing and the service side at the same institution don't communicate on any sort of regular or meaningful basis. And I know from other experiences that's not unique to California.
Absolutely.
Yeah. So, yes, go ahead.
This may take us back to the one. I get comfortable. I'm going back to the mandates, and I've been thinking about that. You know, who should do it? Who should be the driver? And we talked about it may be a long-term goal, so this might pull us into that.
Somehow these margins have gotten a little blurry.
Blurry. So we go back. We talked about the partnership. We've talked about academia. We've talked about looking at our partners. We've also talked about our organizations. We also threw in IOM in there. So as we were talking, I thought, what has, and I'm from academia, so what has pushed changes in academia? I need to come back to IOM reports that said to us, transform and change, and guess what we're doing? We're transforming and changing. So sometimes I think that partnership with IOM, if there was a hint at a mandate or a very strong hint that things need to change, I think we might see some changes.
And what might that hint look like?
First, we've got to do the research. What does it say? You know, what should we do? You know, should the mandate be that if the individuals there's more certification, organizations and individuals that we can pull it toward improving patient care, improving you name it, then must be. I don't know.
Judy, you were going to.
Well, this is Judy Martin Holland again. I wanted to ask the question about the mandates. I see that it's underneath the topic or the subtopic of encouraging continuous research activity. And so I'm wondering if the question about mandates was as focused on who would do the activity, who would collect the data. I'm not sure how the mandate question, what to do with the mandate question in my head yet, so I'm struggling with it a little.
Well, it was a poorly framed question, so. It's just that is a strategy that is used in some areas to stimulate research or to find questions, is to say, okay, we're going to force you to, do this. Mm-hmm. And then there's always pushback, and someone says, well, but we don't know, these things, and therefore we need research to determine that. So before you can affect the mandate, whatever it happens to be, we have to answer these questions. So it's a way that has been used. to encourage investigation into certain subjects, usually not by design, but as a de facto approach.
Thanks for the clarification.
And I'm not necessarily recommending that's something
Right,
we should,
right.
but as we
Yeah.
think about what are the levers that we can change, what's driving healthcare change today? What are the levers? Payment models. Probably the strongest lever that's driving change has to do with payment. Information management is another powerful lever. Regulation, or in some cases the lack or deregulation, is another lever that's being used in healthcare widely today. And there's a handful, and it goes back to how do you change a complex adaptive system? Healthcare operates as a complex adaptive system. You can't micromanage each change, at least that doesn't work. So you have to find what are those change levers, those things that if you tweak them a little bit, you actually will get large change in lots of ways. And payment is one of those things, at least in healthcare, that is a very powerful change lever. So that's, in some ways, that's kind of the exercise. What are the levers translated into strategies to encourage research in this particular area? Other thoughts? In the back?
Marla Weston from the American Nurses Association again. This whole conversation about mandates has me thinking in a little different track that I thought I would share, and it might stimulate some conversation. And that is, what people really care about in the healthcare system right now is how to improve quality and how to reduce cost. And if we in this room believe that certification relates to those things, one of the places that my head started going is, who else really is a driver in reducing cost and improving quality? So it's organizations like Joint Commission and NCQA and IHI and those organizations. And so many of us in this room sit on advisory boards or consultation to those organizations. And I think in some ways generating this question inside of those organizations and get them to assist us either in collecting data or doing research or crowdsourcing or something could be another lever to really get some momentum going in research in this area.
Let me throw something else out. Is public opinion and just how people think, is that a lever that would encourage research? Is that a strategy that we should pursue? I mean, I think many people have certainly seen the campaign about nursing that are, very powerful. I think is very effective in changing, or at least in some cases bringing into the consciousness of the public the role of nursing. Is this an area where perhaps there is this public dialogue or communication is a strategy that could be used to promote this agenda? Again, not recommending it, throwing it out as something, whether you have feelings on one way or the other. Seems to have gone over like a lead balloon. Yes.
Maria Shari, ABNS. When you think of the major focus of Credential, which is consumer protection, we have not really discussed the patient experience, the public voice, and that is an area that we must not ignore.
I mean, one of the major drivers for change in healthcare was this consumerism. Is that a strategy, or is there something there that could be used to drive this agenda in a meaningful way? And if so, what? How do you turn this nebulous idea into something that's actionable? Are we at a point where we want to shift and start thinking about longer term strategies? Or have things so morphed that that distinction is almost arbitrary at this point? Or, and let me actually ask that as a question. When we think about and in the committee and setting up this, thought in short term, 1 to 5 years, long term, 5 to 10-year strategies, is that actually a meaningful differentiation, or should we just be thinking about strategies because they're all going to take probably longer than we would like?
Maureen Cahill again from NCSBN. Just in the short-term part, I guess I would throw out the question. I think it's very interesting to talk about the consumer advocacy and sort of how that ties into nurse certification. And right now I'm really talking about voluntary certification, right? Can we say that across all these certifications, there's some common content, for example, about quality care and safe patient outcomes? Would the CUSIN foundations be represented in these voluntary certifications? Is there, I remember my physician colleagues when the board recertification became a requirement, and part of that argument was that quality and patient safety content was embedded in those recertifications, and that was the reason it needed to be mandated. So if we talk about mandating, do we have enough knowledge to know that there's a base that's common in all of these different certifications? I just throw it out there.
So does that become a research question in and of itself?
Could be.
Okay. There are some people who haven't voiced any opinions.
Cindy Miller
And hopefully that will make you uncomfortable enough that you will say something.
Cindy Miller Murphy, ONCC. Well, Mari, you really made me think about that, because if we look at our content outlines, our test blueprints, I don't think it's really spelled out, but it should be inherent within it, across it. We did a study a few years, maybe 12 years ago, about end-of-life care, which should be embedded in all certifications most of the time. And we could use the same kind of a design to take a look at where exactly is that. It was palliative and end-of-life care, and we found that it wasn't really in most certifications where it should be. So I think that's a great idea, because I don't know about the rest in the room, they're certifiers, but it makes me really think where we pull that out. I'm not sure.
What have we not focused on or not raised that should be on the agenda? Again, this is a distillation of this conversation will appear in some form in the IOM report, and there's been some comment that IOM reports actually may have some meaning and import when they get promulgated. So what things have we not talked about that you would like to see as part of this conversation about strategies for encouraging research in this area?
Hi, I'm Kathy Kobler from the National Board for Certification of Hospice and Palliative Nurses. And when you were speaking to levers and information management and technology, I mean, clearly we heard expertise and wisdom yesterday from all the different panel members that is beyond the reach of what nursing knows about how to manage data and how to extract from current electronic medical records. And I think there's got to be some way to address that in order to get at the points we need to reach within our data.
As a pragmatic matter, whatever is done to encourage research in this area is going to have to be grounded on data, and data that's reliable, that's meaningful, that answers or is potentially able to answer the questions. So actually coming back to that differentiation between short-term and long-term strategies, it would seem that in the short term, high priority should be given to ensuring that we have the data and the tools to manage that data to facilitate whatever type of research may ultimately be done, but that creating those databases and supporting them or finding ways to support them should be a high priority for efforts early on. Anyone disagree with that? Okay, comment?
Of this whole task, given that this is nursing focused. But I'm wondering where teams fit into this. And having just developed a stronger relationship recently with the American Board of Medical Specialties, I know that they share interest in a lot of these very subjects as it relates to physicians. And they're interested in looking at this and partnering where we can. So keeping in mind IOM's recommendation many, many years ago about looking at this from an interdisciplinary perspective, I just wonder if we want to lay that transparency across this.
Okay, translate that for me into how that is a strategy for encouraging this, or how that might look when Claire types it out.
That one of the partners in this could be other interdisciplinary professions, such as medicine in this case, that they may also share the same interests in looking at research, but from a little different perspective, but that there's lessons to be learned by each.
So building coalitions and partnerships to stimulate research.
Right. But not just within the nursing circle.
Right.
Yeah.
Okay.
Holland. Judy Martin Holland. So I want to go back, my brain's a little slow, to the mandate question. And because I started to think about other stakeholders in quality of care provided in hospitals. And it seems to me that if you're at the state and you're licensing facilities, that you may have an interest in learning more about the quality of care provided in those facilities you license. And so you could create a fund that comes from licensing fees that would pay for research on quality of care, in which then we could, or our researchers could provide proposals and a research agenda to help fund research in the area that would connect to credentialing. But so in thinking about mandates, I thought more of the state structure and what their buy-in might be to looking at qualities and facilities that they license.
So another way that could be operationalized, since licensure is at the moment at least a state function across the board in health professionals, is that states could decide that they're going to assess a fee for research to support this, and that of course would require a proponent to advance that among the boards, licensing boards, and then affecting it, and then how it might get managed as it went forward. But it would be a way of potentially both encouraging funding as well as stimulating some research in certain areas. Yes.
I'm Nicole Telliard with the PNCB. I'm the president-elect for the Pediatric Nursing Certification Board. And this has all been very good discussion and has been very interesting hearing some great feedback. One of my pieces that I was thinking about when she spoke about the healthcare environment and some pieces that we've seen, my background is Vice President of Children's Services in a children's hospital. And we've seen some great work come when we join consortiums of children's hospitals together to look at whether it's patient identification with parents and babies, or whether it's IV infiltrates and those things. And we do that and compare 10 to 12 different teams against children's hospitals and do some poster presentations and those things. So it just got me to thinking when we were talking about DNP or PhD projects and those things, if that might be a good relationship to partner with the schools of nursing, that we look at those team components when we're comparing different hospitals and our IV infiltrates and those things, that we look at whether teams of nurses with voluntary credentials such as the CPN might have outcomes that are different when we look at teams, because as we heard yesterday, it's very hard to look at that from an individual nurse perspective to say that you're improving these patient outcomes. So just more food for thought.
Great question. Take it just a little bit further in how that question then actually becomes a catalyst for stimulating research. Does that fall into a priority? I mean, it's, you know, it's going back a bit, you know, there seems to be by assent that data and getting the data side of the house in order should be a priority early on if we're going to do research, and that would be a catalyst because you'd have good data. Then another area that may be having priorities, clear priorities for what are the most important questions to address in some sort of sequence. Would this fall in that category, or are you thinking of some other way that it would catalyze research?
Well, with these two events, it was groups of hospitals that elect to participate with the Pediatric Hospital Medicine. They were both actually led by physicians that were with Pediatric Hospital Medicine Society that come up with special projects that they want to compare children's outcomes, and they look for voluntary organizations to be a part of that. And in those instances, both examples, we've had internal nurses take these projects on for career advancement programs and career ladders to do special projects. And they've done a lot of data gathering to share when we sign these affiliations that we are willing to share our outcomes data on these pieces. So certainly our hospital nurses are beginning to get into that data collection mode and really take this on. But then too, it led me to think that that would be a great project. I'm also a DMP student, so finishing up my capstone, that would be a great project for someone in school to take that on and partner with these children's hospitals and join their consortiums and kind of have a ready-made project waiting for them.
Was a stimulus for that? You mentioned that there were a couple of docs that you know kind of got behind this, but was a stimulus basically a health system saying we need to improve our performance because we need better outcomes, either because the payers are demanding it or because we think that this is just, we should be doing better? Or what was the genesis before you got involved?
And I think for us in children's hospitals world, we don't have as many core measures or perfect care measures and those things. So it was a way for pediatric and children's institutions to partner with each other on special projects that groups of hospital medicine teams felt like were emerging trends that we wanted to research and really evaluate our outcomes, because there's not as much of that in the children's world with SCIP. You know, the core measure that we really compare right now is asthma, so that we're not as far along in the children's healthcare world as the adult side with some of those outcomes. So this group of hospital medicine team has really gotten together and looked at identifying what their topics of focus are and really trying to get some consortiums together to look at that.
I saw a hand somewhere here. Yes.
Maureen Cahill again with NCSBN. I think I understand what you're saying is there are a number of quality consortiums that are out there. Do we know what the penetrance is of certified nurses participating in those organizations? QOPI for oncology, the Children's Consortium, University Health Consortium. Those are easy databases to access and know. Does it matter? Are these, so instead of being able to say, you can relate individual credentialing to outcomes, you can certainly infer that that group might be more participative in quality consortiums than others. So that'd be an easy thing to study, I think.
One of the pragmatic realities, at least in the hospital community, is that there's a lot of collaborative and quality improvement fatigue these days. I know I work a lot with the California Hospital Association and the state on various things, and the quickest way to turn off CHA is basically talk about another collaborative. I don't think that's unique to California. So, you know, that's an issue that as we think about how to operationalize this, we have to be mindful of all the other activity that's going on and whether this is going to be a burden or actually perceived as something that's useful. So where, I want to try to drive we have a half an hour left. We don't have to use all that time, but I do want to try to drive us to some sense of the prioritization of the strategies that we've talked about, and data and getting the data house in order seems to be near or at the top of the list as far as a short-term priority. Because if you don't have good data, you just can't do research. Second, seems like getting priority or getting some sense of what's most important to pursue. And what I've heard people say, and this is a reality check, is that there actually is pretty good agreement on what those priorities should be. Although perhaps they've not been articulated as well or as clearly as they might be. And that might be perhaps a second short-term high priority, is getting clarity and a clear articulation of what are the priorities that should be addressed in the short term, ignoring for the moment what those priorities might be. Am I hearing correctly, or is my hearing going bad, as my wife tells me? What should be next on the list as far as, we talked some about funding, and again, it's hard to do research if it doesn't, if there isn't money to support the people to do it. That funding may come from a variety of sources. Where does the funding issue fit in this priority scheme? And how do we convince funders that their money will be well spent? I mean, I've been on the boards of a number of foundations over the years, and the question always is, well, how do we know that we're getting a reasonable return on investment for the dollars, and often large amounts of dollars, that are being devoted to an area? How do we convince funders, whether it's philanthropy, the government, business coalitions, other payers, that this is actually would be a good investment? Sir.
Rick Meadows, American Academy of Nurse Practitioner Certification Program. One of the things that I think we might have assumed and perhaps overlooked with this whole process is the incentivizing that has to occur. If you get an incentive out there, then I think that the funding will be generated secondary to the incentive. The people who want to have the research done in certification credentialing, I would assume, are really the people that offer those credentials. Am I correct in that assumption? So how do we incentivize individuals to put their money forth to help with that research? And I guess that's a question that I have as opposed to an answer.
And when you are thinking about incentives in this regard, what particular might you be thinking of?
What's in it for me? Very simple. I have
That's
to.
how most incentives work.
Yeah. I have to see a need for something before I'm willing to engage in it, to be honest with you. Philanthropy is one thing, and that in and of itself is a need. It's an internal psychological need, but it is one of the incentives. And if there are philanthropies out there that would be willing to put money forth, they still have to be convinced that there's going to be something that's necessary and beneficial to them. So those are the things that I think that one of the things we need to at least address, and I'm not sure if we can come up with an answer or not.
Reactions? How about this notion of incentives? Are there other ways that we should think about incentives to stimulate this? I mean, again, funding is often becomes an incentive in and of itself, but that funding has to come from some entity, and there often has to be an incentive for that entity to make the funding available that create the incentives. I mean, there's this chicken and egg or whatever metaphor you want to use.
Going back to the organizations, question to the organizations would be this. I'm thinking about the core competencies for interprofessional that just came out. How much incentive was it to the organizations to be a sponsor of that paper? So then going back to, you know, everything we've talked about, the recommendations, et cetera, is one of the incentives that if they sponsor, they get their stamp on the paper? Just a question.
Other thoughts? These two hard questions for this early in the morning? Who haven't we heard from?
My name is Paul Masmanian. I'm with Virginia Commonwealth University, and I'm a member of the Standing Committee. Take them a good proposal. You know, if there's, just as we've been talking about collective funding, a good collective proposal would, I think, incentivize funders and also would help us to build some of the capacity that Vicki was searching for when she talked about getting some of the academic institutions involved.
And how do we generate that good proposal? Any thoughts on the ways to operationalize that in the next 6 months?
Well, we have willing and interested folks here in the room and leadership here in the room, and I suspect that's where it will come from.
Is there a role for the standing committee or some derivation of the committee to weigh in here?
I suspect that the standing committee, I only suspect, would be very supportive of efforts in that direction. There was an IE next to the IOM in an earlier sentence, and I wondered if there were other organizations that might also collaborate or be facilitative in some way.
Like the NQF potentially.
That's clearly one that comes to mind.
Yes.
Maria Shari, ABNS. When we talk about incentivizing, we also need to have strong simultaneous messaging. And so as we move forward, I don't want to lose sight of us crafting powerful messages that can convey the importance of what we're trying to achieve and why different segments of our colleagues would be interested in participating with us.
Just as an academic point in change strategies or change efforts, the one area that is most frequently overlooked is strategic communications. And there is a whole body of knowledge behind strategic communications. Who is the messenger? What is the message? Who are you messaging? Et cetera, which is largely overlooked. And so the question that was a long-winded preface to the question is, should we be, as part of this effort, should there be a formal strategic communications plan that creates the fertile ground for research then to take hold of it? And is that in and of itself, having such a strategic communications effort, does that in and of itself become a catalyst for stimulating research? And is that something that should be in the immediate short term, long term, both? Weigh in. Thoughts? I see a lot of head bobbing, and I don't know that you're going to sleep.
Hi, it's Judy again. I absolutely agree with the comments that you just made and the strength of them, quite frankly. And I think communication has to go before funding in terms of priority, because you can bring more people on board if they know what your purpose and your activity is. And I think both of those need to be towards the top of the priority list, and they need to be immediate.
With any political campaign, one of the first things you have to do is you have to create the receptive audience. You have to create the conditions for which the message is then going to be delivered to. So we'll put strategic communications up near the top along with data. We have funding. We have incentives, although I'm a little uncomfortable as to how or what we're going to say with regard to how that gets operationalized. Let's come back to the idea of internally generated research, whether it's within academic health systems, whether it's within large provider organizations. I mean, if you take an entity like Kaiser Permanente, they have actually a strong research program that does a lot of good things, but the genesis of it has to do with how does that information feed back to create or make their system better. VA likewise has that, although there's always been tension of whether that is going to be targeted enough to what the mission of that organization is or whether it's more global. There are other entities as well, and we heard yesterday from some of the health system representatives about their efforts internally. Should that be, somehow do we bring that in as a strategy? We try to mobilize and energize health systems to embark upon research because it's in their own vested interest. I mean, where would Hopkins come down on something like this? Not to put you on the spot, but I will.
Karen Haller, I think the appeal of Hopkins funding research in partnership with other people is high, and that's what we've done on the multi-site studies. We have put in our share of the money with others to fund a very large grant. So I think we'd welcome this. I think in all this conversation, I'm just reminding myself that the research question has to sort of be a null hypothesis. You can't go in assuming that you're going to prove that 100% of credentialed nurses make a difference. You have to be open to the findings that may show something far different than that, because most of the conversation here has assumed that certification, if we did the research, it would be found to be a good. I'm not sure that's necessarily the findings. We have to be open to all the findings. We might find out that there's a certain proportion of nurses who have to be credentialed to tip the organization. We might find out that the unit of analysis that's relevant is the unit, not the organization or the individual. So I think we have to be neutral in our approach to the research to appeal to the academic institutions. Did I answer your question?
I'm thinking about it. I think a good example of I think part of what you're describing is what's gone on with the hospital engagement networks as far as a quality improvement effort. I mean, they're kind of all over the board as far as the rigor and the value of the information, that is being put forth from this billion-dollar effort to encourage quality improvement. And there's some good things have happened, but they may not be quite as good as some of the rhetoric that's been used to describe them. Yes.
Sharon again. I have a question for organizations. Have the organizations ever come across one focus that they've all gone on the bandwagon, or would this be something different? Does that make sense?
When you say one focus, what do you?
Okay, so you're looking at the different organizations and they're all going to choose credentialing as their focus for the next 5 years or the next 2 years. Has this ever happened before where it was a unified focus? And I'm just thinking if it's new, then that's something new to communicate, and you can utilize it as kind of your banner to go with. And I'm not sure.
So are you asking whether nursing as an
Nursing, yeah.
enterprise can come together and unify behind at least a single focus, or maybe
Or
other
the
focus? but-
organizations.
Yeah.
Okay, or the organizations. And I'm just curious.
Anyone have the answer to that?
Melissa Beal. I don't, and others obviously are in the room are very qualified to speak to this as well. So I'm just going to put in my perspective from ABNS. We have unified, the certification organizations have unified around credentialing research. So we've all said, well, we're all going to do a national study on the value of certifications, for instance. But I think you're asking something different. Have we looked at nursing organizations, maybe what we would call membership organizations, having a focus on valuing credentialing and credentialing research? I don't think that has happened. I don't know that we here in the room can speak on behalf of membership organizations because we're mostly representing certification organizations. So we have a history and a model that has worked where we have worked together collectively to move the research agenda forward. All of us in this room have done that. But I don't think that's quite the thing you're asking.
Shannon Carter, operating room nurses. I will say, building on what Melissa said about membership organizations, some certifying bodies are embedded within their membership society, some are completely separate, and then there's all kinds of hybrids. But there is data out of North Carolina around the value of certification to membership organizations. And that was commissioned by the American Society of Association Executives. And there is I don't know if it's a scholarly paper, if it's a white paper, around what certification does for membership associations. So if you're looking for something to kind of galvanize the interest of membership societies around why they should care about the value of certification, there is some data around that for what it's worth.
Yes.
Cindy Miller Murphy. Interestingly, our Oncology Nursing Foundation has had a research grant for years with priority for credentialing research, and they don't get any proposals. It's, that's the priority. And actually, I think, yeah, ONCC does fund a piece of that, 15,000 of it or something, but they don't get any proposals. So just to throw that out there, I'm not sure if there's not interest in doing it or what. But yeah.
And this
Could
is
be.
Shannon Carter again. AORN Foundation has the same thing. I know, I believe ICE is looking to, start moving some funding to credentialing research. But again, I'm not sure that we're recruiting, you had mentioned doctoral students, and, I always hear that, oh, well, doctoral students will want to do it. I'm not hearing doctoral students lining up to do it.
So the question I would pose, at least based on some other things I've been involved in, is that often the level of interest and the degree of response you get to RFPs or whatnot depends on the amount of funding that's available. And is that an issue that may be at play here, that the amount is just not sufficient to stimulate folks to come up to the plate? I mean, it's as much work to put together a proposal for 25,000 or 50,000 as it is for 5 million in most cases. So, where do you prioritize your effort?
Vicki Lundmark, ANCC. I had a discussion when I first started working with ANCC, maybe 8 years ago, with faculty members across the country, just 3 or 4, who were talking to me about this, their doctoral students who wanted to do research on certification, and I was just becoming used to the literature. And what I've learned is we have very few models of good certification research, number one. And number two, talking to those people, I couldn't recommend them to any good data sets. ND and QI was just getting started at that time. And even when it got better with the certification variables, it was a while longer before it became available to researchers. So I think the student interest could be there for your grant. But one of the things I've hoped might come out of all this work with the IOM and this workshop is that we finally do get to some good models of research studies and some defined databases. Melissa and I have worked together before, and I know you've worked on a research agenda at ABNS, we have at ANCC. I still think we could use some refinements and to prioritize some more specific questions, because that will help to model some studies that are really done well. And deal with the confounding factors that we've heard about. And then I think that can help to stimulate the growth, to answer your question from 30 minutes ago.
And the only way that you get good models is that if you stimulate research and there is enough out there that you have choices and are able to look at the field of what's better than others. Yes.
I wanted to follow on to Vicky's comments, Karen Haller, Johns Hopkins. I think you have to interest faculty in this work so that it continues over time, because faculty have students year after year after year. They have a cohort of students. So it's not just one doctoral student finishing a study to move on, but we need to engage some faculty in this field. And I also wanted to comment on your point about the amount of the grants, because I think that's key. I think when we offer $20,000, we're not going to interest the field. What we did with the multi-site studies out of ANCC was offer somewhere between 600 to 800,000. Then we got the field's attention. So, you know, I think it's a larger amount of money that'll attract attention.
Right. Is going back to your point about faculty, should one of the strategies that we think about is getting high net worth individuals or organizations to endow faculty positions that are focused in this particular area? Is that something that should be thought about?
So I think that's a useful idea, and I also think there are funders who fund nursing endowments at major academic centers who may be interested in this as well. Because we all have donors who endow faculty chairs. If we could find a donor who would endow faculty chairs in this area at a couple different schools, we could perhaps make more traction.
But that also goes back to the point is that those individuals or organizations who might be endowing have to understand that this is an issue and have to develop some rapport with the issue and decide that this is where they want to spend their money in endowing it as opposed to something else, which gets at the communications piece of this.
Exactly what was in my mind. That's where your strategic communication is essential and needs to be done up front.
Maria Shari, ABNS, also faculty. I'm a professor at the University of Alabama at Birmingham. This type of research is not done by just any type of individual. This is health systems research. And typically, it's not those researchers who we have brought into the fold. So I would make a plea for us to bring those people into the fold. And Linda Aiken is one example of an individual who has helped us move the organizational credentialing piece forward. And people like her and groups like her are individuals who can help us advance this science. The other piece of it goes back to the funding. And several have mentioned here, the amount of funding needs to be worth it. And so I would ask all of those organizations who have small dollar grants to fund this type of work, could we explore a collaborative approach where that money gets pooled so that we can generate a substantial amount of dollars to attract those individuals and those teams that can get us the answer to the research questions that we seek?
All right, we have less than 10 minutes left, and while we've done some of this already, I'd like to try to focus the last 5 minutes or so on seeing if we can get agreement on how we want to rate things, because we are going to have to present this out. And by the way, if anyone would like to do the presentation, I'm more than happy to share that. Any takers? All right. So, data, strategic communications, priorities, funding. What else do we want to put on our list? And do we want to say that this distinction between 1 and 5 and 5 and 10 is too arbitrary, and that there are clearly some foundational efforts like data that need to be done, but otherwise we need to be thinking pretty much in the long term? That, okay. Other things that we've talked about, the other levers, mandates, coalitions. You want to start at the top, Claire, and kind of scroll down to see what what's been captured there that we haven't talked about. Okay, so data, and this is all going to get distilled into probably 1 or maybe 2 slides for when it is presented or shared with the other workshops. Keep going. Priorities. And anyone sing out as we're going through this? Funding. Information management, is that part of data, or is that a separate strategy? I mean, the information technology is not quite the same as the data, but it's very hard to do anything with data if you don't have the information technology, and the information technology often tends to generate the data. I mean, you know, they're pretty much connected, albeit different areas. Yeah.
Paul Masmanian, Virginia Commonwealth University, and I'm less familiar with accreditation requirements, but I'm looking here at mandates and wondering whether the question again of building capacity or importing health services researchers might be addressed by looking at our individual accreditation requirements or certification requirements and focusing more specificity on research in this type of, in this topic, certification or credentialing or health systems, health services research.
Any response, comments? Yeah.
ANCC. As Paul was starting to speak, I was also thinking about the strategic communication. We cycled through in different places several sort of targets of our communication. You know, other nursing organizations, Marla mentioned some of the groups that are interested in quality improvement. We're talking about, so maybe a bullet list of those groups would help under the strategic communication. I think it's a little scattered through the slides, but I thought there were many good ideas there.
All right, and part of what will happen here is that we'll gamish something together for the report out, but all this information will remain and will be massaged further as the report makes its way through the drafting and promulgation process. Yeah, in the back.
Thanks, Vicki. I notice a bullet under number 2 there that says that strategic communication is a higher priority than funding. And I'm not sure I would agree with that. Because I think if we have the funding, people find out about it. And that is a communication in and of itself. So I just would be curious about other people's thoughts about that.
Would you perhaps agree that they should be concomitant?
Yeah, I do agree that it is an important strategy. What I'm questioning is whether it is a higher priority than funding.
And I think how we how we rate these, 1 versus 2 versus 3 is at best arbitrary, and there's kind of a bucket of things that you need to do early on that are all related. And then there may be some other things that will come later, but I don't know what the criteria would be for separating this out, or at least in the time that we have. It'd be hard to determine where one would, you could argue both ways, that what might be higher priority in the short term, but both are essential. Why don't you keep scrolling down, see what we've missed or not. Okay, why don't you go back to 5. Anything else in this area of mandates? I mean, we really didn't, and I'm not proposing that we do what, I actually don't like mandates, but they are a strategy that is used. Is there anything else there that we want to say, or how do we, is this something that we should think about but not advance at the moment, or how would you want to position this to the rest of the workshop participants? Okay. Okay. So one of the things that may not be as well called out as it might be is encouraging intra-organizational or inter-organizational, for lack of a better term, self-serving research. That it's in the interest of this entity or their partners to answer these questions, just because of the world that we live in today and payment and other issues. I saw some hands in the back. Yeah.
Maria Shari, ABNS. I wanted to go back to number 6 and seek validation from the group, because I thought that I heard in number 6 that this was somewhat of a response to the quiz in question. And that was, were we integrating that into our certification exams? And as I look at number 6, I don't see any of that. Quality, safety, education, and nursing.
Yeah, over here. And we have about 1 or 2 minutes, and then we're going to have to call this to a close.
Just along those same lines, end-of-life care shouldn't be up there. I mean, I was just giving that as an example of something we looked at years ago to see whether it was included, but quality and safety are what need to be there.
Okay. And part of the difficulty here is distinguishing what are the strategies to catalyze and incentivize and stimulate the research, as opposed to what should be the content and the subject matter of that research. And in some cases, the distinction gets a little blurry, but they are separate issues. And what we're trying to focus on here are really the strategies to make whatever the subject matter is happen. Any final comments before we bring this to a close and try to wrap it up? Yes.
On the research needs, we have quality, and I know if we're looking at CUSIN, quality part of it is interprofessional, but I think we should put interprofessional there also, okay? So quality, safety, education, interprofessional collaboration or teamwork should be a component.
Okay. Entrapment research. Okay, I thank you very much for your active participation and engagement, and we will call this to a close, and I think we have a few minutes before we will reconvene. Actually, there's a break, and there are boxed lunches out here that are supposed to be collected, presuming you wish to consume what's in the boxes. And then we will reconvene at 11:20 for presentations on these.